Okay, so week 5, halfway through almost, we're going to be doing the chapters on children with sensory or neurological condition and muscular skeletal conditions. This week, there's a discussion question that you should have already posted, the first part on Wednesday. Of course, the quiz, and then you have your 50 NCLEX questions. Remember those NCLEX questions? You can do as many times as you want to get the best number that you want. You don't have to do any rationales on them. Just redo them until you get that number you want. I do suggest that when you do them, to at least get the minimum of a 78, because that's what you need to pass the course, right? And you don't want NCLEX questions to pull you down because you didn't do them well. And that's just a hint that I give you. Just try to do the best you can, because case studies, you only can do them once. So if you don't do well in case studies, at least you have those NCLEX questions to help boost you up. Okay, so today we're going to be doing the PowerPoint first, and then we're going to be doing the Kahoots that I have. Be aware that all of you, except the Tuesday girl, is going to be getting the recording. I usually will post it by 6:30 tonight. So you'll have them pretty quick because next week is your exam, right? I'll also make sure that if Professor Yamraj hasn't posted the exam reviews, that I will post them. Just to let you know, nobody went to her review yesterday. So there's only going to be 2 reviews that you're going to get, okay? Nobody goes, you don't get a review because there's nobody to talk to. So, Lorna, is your last name that M.W. Wamza? Because you came in with a name of Lorna, and you'll not get attendance with that. And it's the only Lorna I could find. So, are you Lorna Wanza? Lorna, can you hear me?
Yeah,
All right.
that's Lorna.
Okay.
Lorna, that's
Thank
her.
you. Thank you for helping me out with
You're
that.
welcome.
Probably she couldn't get herself off of
You probably
mute.
can't hear.
Yeah, when something is going on, it's okay. All right, let's go ahead and let's do our PowerPoint. Any questions going on so far?
Did you say that your exam is next week?
You have an exam next week.
Okay, do you have a worksheet, like you know how we did the sheets where you fill in the answers like you
It
did
is
last
not a
time?
worksheet like that. You're just getting the PowerPoint. The
Okay,
first one that we did it with fill it in, which
no
really
problem.
matched up with the PowerPoint. But from now on, it's the PowerPoint, which gives you all the everything that you do need to
No
be
problem.
successful on that exam. Okay?
Thank you.
No, you're very welcome. So let's go with some PowerPoints, talk about them. Remember, anytime you're not understanding, stop me. I do not mind. And I'll explain it to the best of my ability, okay? I've been working in pediatrics about 25 years and teaching it for the last 5 or 6 years. So I think I have a really good concept. I don't know everything though. So sometimes I do have to look stuff up too. So let's go with the sensory neuro problem first. Well, sensory, you think senses, we think of ears. Ear is a sense. We do hear from it, right? One of the things that can happen, and I live in South Florida. I live in Homestead. I'm about 30 minutes away from the Florida Keys. So yes, I have a pool in the backyard, and yes, I go to the beach as much as I possibly can. One of the things that can happen is the ear is painful. You just touch the outer ear, and oh my goodness, you'll scream. And that's called swimmer's ear. It's just the outer side. It hasn't gone inside yet. It's not the inner ear. And the way that we treat these are just the little topical antibiotics that just go in there, just like an ointment, but they're a liquid. They go in there and they do take care of the swimmer's ears, okay? One of the things that you rule out, if it's that otitis media, the middle ear, the external ear, is we look at it. And the inner ear, the membrane looks good. It's not bulgy, full of pus. We can say that. Also, looking out to see if there's anything in there. I've seen some crazy thing in ears, like pieces of crayons. pieces of little pencils, colored pencils. And the one of all that I still remember is a live cockroach. Little cockroach had crawled in to this poor little child's ear, and it was creating a lot of pain. So making sure, what are we working with? Is it swimmer's ear? Is it a foreign object, or is it the middle ear? So otitis media, this is the inflammation of the middle ear. You look inside and you see that tympanic membrane and it's bulgy. And you can see, and it sort of gets white color and it stretches if you look at it. And this creates a lot of pain. I mean, there's pressure building up in the small area, which is connected to a lot of nerves, and it creates a lot of pain. One of the things with otitis media, it's from the upper respiratory mucus. There's these little short, straight eustachian tubes, and mucus has to go somewhere. Well, sometimes it goes up into the ears. That's why children get a lot of ear infections. Sometimes it could be just a sore throat that causes the infection to go up in there. What do you see with otitis media? Well, many kids will be crying holding their ear, and they'll tell you which ear hurts. And I like it how they take the right hand and they go across and they go the left ear. And I'm like, oh, you poor little thing. A lot of times I'll try to give them a, heat bag, little heat pack that you can get, those heel warmer things, put them on the ear. Kids don't want you even touching it. So you're going to see them rubbing, pulling at it. These are your young kids that can't tell you my ear hurts. And that's going to show you the location because they're banging their head or they're rolling it or you could just see something's not wrong in their head. I mean, if it's throat, their hands are down their throat. So they can show you this stuff. If we let it go on, there's going to be hearing loss because middle ear is full of pus and infection. Sometimes these children that are older, all of a sudden they're talking louder. It's because they can't hear. And we know speech and hearing are connected. If you do not hear well, whether it's from that infection or some hearing issues, your speech is going to be changed. It's going to be, you're not going to be able to articulate the way you should. The pronunciation's not going to be good. And they're going to be trying to speak louder because that's the way they hear it too, okay? Also, they're going to look like they're not listening to you. So that could be a sign of ear infections or even hearing loss. So what do we do with otitis media? It is an infection. Make sure that this child takes all the doses of the medicine ordered twice a day, usually just an amoxicillin or a augmentin, depending on the doctor, something that takes care of staph infections, because staph is always in us, in our upper airway, always, no matter what. When it gets in the ears, when it creates the problem with that mucus that pushes it in there. But we take all of the doses twice a day for 10 days. They should finish it, all of it. Now, some of the times we're going to also give those ear drops. Remember, pull it back, pull it down and back for infants and pull it up and back for your older children. It just opens that canal that you could get eardrops in there really well. And if we see that they are chronic ear infections and they're always with this pain in their ears, etc., the doctor might even consider putting ear tubes in. And sometimes it's more than one set. Could be 1, 2, 3 sets of tubes because they fall out after a while. I know my second grandson, he had to have them 3 times. And they finally put in like titanium tubes or something to try to keep them in there longer. So, talking about hearing impairment. When we're born, before we go home, they must do a hearing test now. It's one of the state laws in every state. You need to check it as quick as we can. Hearing loss is when the tympanic membrane blocks the sound. It doesn't go to the middle ear. That's conductive, okay? It's called conductive hearing loss because it can't conduct from the outer ear to the middle ear through that tympanic membrane to the inner ear. It doesn't go. It's called conductive ear loss. Now, some children, as they get older, people watch
Oh, no,
children
I'm sorry.
with not even the same language, and these children can communicate without even speaking. This is what kids with hearing loss do. They can read your lips or just the way they show you things, gesturings, etc. Body language, all of that stuff shows what they're communicating. We know if it's a true and real hearing impairment, we'll be teaching them sign language so that they can talk, speak. I mean, my kid always knew what this meant, and that meant I want more. Like, you want food, and they go more. Even before they said mama and dada, my last grandson does more. So speech is, always incorporated, teaching them how to express themselves. So when you are with a hearing impaired child, that kid doesn't necessarily hear you if you're walking away from them and not facing them. So we know when we approach a child, we always get on their level. We're above them, we're towering down, and they're going to be threatened. If they're sitting in a bed, I'm going to get on a chair and sit down below them. So I am a little bit below them, and they're not going to be afraid of me because they're bigger than me, right? Makes a big difference. So be at that eye level, face to face, have them looking at you and have their eyes looking at you. The other thing is short, quick sentences. And don't try to exaggerate or talk louder or stuff that you might be intended to do. Just short sentences. And as you're asking that, do you understand? And these children, do. So when you treated them with these exaggerated movements, they get actually sort of offended. Like, why is she talking to me like that? Now, there's visual types of impairments. There's nearsightedness and farsightedness. Now, nearsighted is you can't see far, and farsighted, you can't see near, which I'm like, okay. So knowing myopia and hyperopia, and these will need glasses of some sort. And there's some other things that can happen to the eyes. We could have these, what we call strabismus. And strabismus is when you have two eyes. Now, we've talked about infants with binocularity, or they see one eye out in the other eye, but they don't focus together. Now, if you put your finger up, both of your eyes will go to it. And now you've got great depth perception, okay? Children with strabismus do not. So their eyes cross the midline, it's called. And then we have to retrain their eyes and get their muscles working better. Amblyopia is one eye, it's lazy. They both work together, they see fine, but one eye could be in or out, or it just doesn't know up or down. It could be any different way. So their muscle in that eye is really weak. So how are we going to make a muscle stronger? Well, we're going to use it. How do we use it? Cover the good eye and let that bad eye work. And we'll do that with a patch, putting it off and on several times a day. And it will make them use that bad eye to strengthen the muscles. And it works. Usually no surgery or nothing is needed. Something else that can happen is called nystagmus. And this is just all of a sudden you see the eyes, they're jerky. And it's just basically jerky movements in it. Sometimes there's a neurological thing that goes with it, but again, usually corrective lenses do help that. So strabismus, amblyopia, we know it's the patch to the unaffected eye and glasses and eye exercises, like I said. And the last thing, as I said, is surgery, but we rarely do surgery for this. So infections, hold on a second. Okay, spam call, we don't need it. Sorry, everybody. Conjunctivitis, don't kids get this a lot? They get these goopy eyeballs, especially in the morning, and they're almost caked shut. And how do we take care of them? Well, this is an infection, and it is very contagious, which means one kid in the house could give everybody conjunctivitis. So how do we treat it? Most of the time, all it needs is antibiotic eye drops. Or sometimes we put eye ointment in at night. Be prepared though, if you put ointment in a child's eye at night, they're going to see foggy and they're going to get scared. So warn them, until it dissolves in the eye good, they will see foggy. Okay, very important thing to tell them, because I think, oh my God, I'm going to lose my eyesight. But just eye drops. Another thing is washing hands between the child and you, and anybody who's involved with the child. I also tell them change their pillowcase every night, at least once, right? Because they're just going to lay down and put their face right back into that infection. And it's sometimes some things that we forget about. Now, a retinoblastoma is a malignant tumor in the retina, in the eye. And you're going to see that white eye look thing. I mean, this is what they used to have when they took flash cameras and had a flash bulb and your eyes would turn white. It used to be like that. Well, today we don't have that. I mean, we've got great iPhones, right? Great pictures. There's no white eyes anywhere. But if we see a white eye, very, very distinctive that this is a retinoblastoma. We call it the cat's eye reflex or leukocoria. Whenever you've ever looked in the back of your yard, and let's say you have like a forest or bushes in the back and the cat or the dog's back there, there's a light on and you see their eyes glow, same thing. That's why we call it a cat's eye. And we need to know that sometimes it is accompanied by other things. That's why with strabismus, we are checking those things to see if it's something organic causing it. So we do laser on them, we do chemo, and we do that radiation. There's a beam that goes into the eye area to the retina. Most of the time, though, they have to remove the affected eye. They have to take everything out. And these children end up with a fake eye that they put in there because they have to take all the pieces out or it will grow again. Now, while checking the eyes, if you all of a sudden see a fixed and dilated pupil, something bad is going on. It is a neurologic emergency. There could have been the kid fell down, has a bleed going on in the brain, or there's a tumor that got big enough all of a sudden. Pupils should be equal and reactive. If there's not, and especially fixed dilated, you need to tell the doctor right away, emergency. Now, what causes the altered level of consciousness in children? I think the biggest one that you see is this low blood pressure. Child's not alert, really not, responding the way they should. We know that low blood pressure is causing cerebral hypoxemia, no blood with no oxygen to the brain. We need that, or you're going to see that restless sort of hypoxic anoxic episode. Sometimes fever can cause this altered level of consciousness. Children that's having 102, 103 fevers, they're not moving around much. They're sitting in the corner and they just want to sleep, right? Not normal for them. So that's their altered state. We know sometimes drugs that we take could cause them to be not as alert. And seizures, of course. After a seizure, there is what we call a postictal state, where they're a little confused after having this type of grand mal type of seizure. And anything that increases intracranial pressure, which could be a brain bleed, which could be a tumor, can also cause that. So here's an acronym for all of your cranial nerves. I know that you've had to learn them. I don't know what acronym that you learned, but I have this one here for you because I think that it's always good to have something else to remember things by. So, once one takes the anatomy final, a good vacation seems heavenly. And that's all of your cranial nerves. So it would be easier to check them. Now, one of the things that we need to be very, very clear with our parents, teaching them how to treat the fevers, that we are never to give them anything with that aspirin. Aspirin can cause something called called Ray's syndrome. There's some sort of correlation between it and the body's metabolic state, and it can create this child to be extremely ill. So we'll never, ever recommend it. And if a mother's saying that she's going to give aspirin, say, no, there's a better choice. After 6 months old, they can alternate Tylenol with Motrin, the acetaminophen with ibuprofen. And we are taught to do it every 3 hours. So at 12 o'clock, you give it your Tylenol, at 3 o'clock, Motrin, at 6 o'clock, Tylenol, 9 o'clock, we'll give Motrin. And you can see it's every 6 hours we're giving that medicine. And that can keep those temperatures down very well. Meningitis. Well, what is a meninges? Let's take and tear this name apart. A meninge is the membrane that covers, it's a fluid-filled membrane that covers the brain and the spinal cord, okay? And it gets inflamed and irritated and infected. Many times it's a virus, but a lot of the times it's going to be a bacteria. We will see that child with fever, headaches, nausea, vomiting, anything to do with the brain and increased pressure, nausea, vomiting, headache, all guaranteed. And then the photosensitivity. So, and then it gets to the point of confusion. So meningitis is an inflammation of those meninges, that fluid-filled membrane that covers the brain and spinal cord. One of the things you see with meninges is different sort of signs. We see the Brudinsky sign and we see the Koenig sign. And when we have meningitis or suspected, these are things that you can do and also the doctor can do. You know, lift the head up. Does the knees come up? If you lift the leg up, does the head come up? These are things that will be classic signs of meningitis. So how do we know if it's viral or how do we know if it's bacterial? Well, it's the cerebral spinal fluid, right? You got to get the fluid out of what's covering the meninges in there, right? Pull it out and look at it. You can tell almost immediately if it's viral or if it's bacteria. If it looks white and milky, that is bacteria. A viral meningitis will be clear, crystal clear, okay? So one of the things with meningitis, they must be on antibiotics, and that you also need them in droplet isolation for 24 hours. You need 24 hours of antibiotics going before they're not that as contagious, okay? These droplet isolation rooms means those reverse airflows. Usually every nursing unit or every other floor has these rooms where the air doesn't return back into the hospital. It goes outside. It's filtered and it goes outside, and then other children can't get it. As nurses, you're going to wear an N95 mask. You're going to protect yourself. And of course, always universal gloves and hand washings for sure. Well, this affects your brain and the covering of your brain, the meninges. So you're going to do neurochecks, seeing how are they moving? Are they responding to stimuli? Look at their pupils, see what's going on. Are they able to talk? Are they able to follow your instructions? Making sure that we are doing those vital signs, making sure the blood pressure is not dropping, right? And intake and output is important. We do not want to overload these children with too much fluid. Too much fluid will put more pressure in there. And because their head is so sensitive and that photosensitivity, keep it a quiet room. Usually these rooms are at the end of the hall, away from the nurse's station. So, common triggering factors for seizures. Now, I think the one thing that I think of when I think of a common triggering factor is fever, right? Febrile seizures is one of the most common things in children. What is a febrile seizure? Well, it is not that they have a fever of 105. No, it's they've gone from no fever to a high fever quickly. Could be in 20 minutes. They've gone from 99 to 102. The brain goes, oh my goodness, it's like sparks, and they have a febrile seizure. Usually it's due to a virus, and usually it's not going to progress any more than that. Parents are like, well, now does my kid have epilepsy? And the answer is no. One seizure does not dictate a child has epilepsy and will require medications, okay? So febrile seizures, once they have the fever, they're good. I know working in an emergency room, I have many parents come in and they're like, oh my goodness, my baby has a fever of 104. You need to treat him right away. And I say, well, did you medicate him with something? They said yes. And I said, well, once you have the fever, your chances of a seizure, which you're worried about, is very negligible. Like it won't happen. It's how it goes from 0 to fever that creates that febrile seizures. My oldest grandson had febrile seizures one time. Well, that mother carried around a thermometer and Tylenol and Motrin in her purse for her life. She still does it, and the kid's 11. And you grow out of usually febrile seizures by age 6. Some of the times where you do have some sort of epilepsy, some seizure condition, there are things that can trigger it. And that's flashing lights. Like these kids to go into a disco as they get older could cause those things. So you have to be careful. Moving too quickly, too much hydration again. Remember, it will trigger there. And again, if it's too light, too bright, sometimes walking from inside to outside and where it's sunny, especially like me who lives in South Florida, it is bright and sunny here. So putting sunglasses on before you move out, walk out would be good. Infection can cause seizure. A fever can cause seizure, as I said. Epilepsy can cause it. Any sort of drugs. And these are important things to remember. Also, if a child's blood sugar isn't at a normal level, it also can cause a seizure. So there are 5 things that can cause a child to have seizures. So diagnosis and treatment. Well, if it was due to a fever, first time never happened, we can say it's febrile seizure. We'll teach the parent to watch the temperatures. And like my daughter-in-law did, carry Tylenol Motrin around with her, and it did help. If it continues and there's more than one, they will go on towards doing a complete neurological workup, which will include things like an EEG, a CAT scan, an MRI, looking at the brain, looking at the electrical activity there. Also, remember, your electrolytes really do affect things like your heart and heartbeat, and it also affects your neurological status. So making sure that electrolytes are normal. So they'll do a complete panel of labs on these child. What drug do we use? Well, it depends on the child. And sometimes it needs a combination of them. And sometimes they change it and change it and change it. There are a lot of families that believe in like low gluten. Diet changes do help with it. I've just seen some new documentaries saying that CBD oil can also help. It was the only thing they changed, and they took the child off all of their medicines. But the one thing I always say with anything that's non-conventional, that the physician's aware of what a parent's trying to do. So you work together, not against each other. So your child, you walk in and you have a seizure, or the kid might have a seizure. What are things you're going to do to keep that kid safe? Because safety is always one of our highest priorities. Well, this child should be in bed with the side rails up, and they shouldn't be out walking around unless they are with supervised people. If they're in the room, anything that's sharp, like sometimes sides of the bed, there's really sharp points. We should make sure that they're not sharp, because they could fall and bop their head and they could really cause a big seizure and hematoma. These children, when they leave, should have a medical ID bracelet, whether it's a necklace, a bracelet, whatever it is, so that people, medical personnel who respond to an emergency can say, oh, look, this child does have a seizure activity, and it can help them treat for them. This is a child that should not be out in the pool by themselves. What if they have a seizure and they're in the middle of the pool? They'll drown, right? So even if they're great swimmers, you can't allow them to be alone. They must be watched. Of course, avoid all those trigger factors like I was just mentioning. I mean, that hypoglycemia, make sure they have snacks, right? Keep those blood sugars up. And if they're on medications, making sure that they're compliant, they're taking it when they're supposed to and how often they're supposed to. Don't say, well, two a day makes my kid too sleepy, so I'm only going to give it one a day. Most likely that child is going to have seizures because twice a day medication usually lasts like for 12 hours. So they need to have the other dose.
Ms. Bogart, I have a question.
Sure.
The diet they're referring to for the seizure, we've learned in med surg that for adults it's a keto diet. Is that the same thing for the kids or no?
Yes, 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 absolutely. They're doing all sorts of different diets with children. You know, they'll do the gluten diet, the keto diet. There's many that they're using today, and some are extremely successful. You know, and if you've had a kid who's had seizures and you've done everything and you're tired of going to doctors and then just them keep loading up the medications, it is a great alternative. It's a great alternative. Yes, that's a great question. Thank you. So cerebral palsy. Cerebral palsy is the nervous system's not working the way it should. When you think of cerebral palsy, you think of the child in the wheelchair who's spastic, right? You see them tense up, that their hands are different sort of positions. They try to eat and they're just shaking so hard they can't eat. That is one of the types of cerebral palsy. That is the one that we would use botulism with. What we do is we put botulism in the nerves that are causing these spasms so that allows the child to be more, be able to take care of themselves a little bit more because they do want to. You know, I've taken care of my little Jonathan was 7 years old where I met him in doing clinicals at with Fortis. And little Jonathan was spastic, so spastic. His hands would be going crazy. And what they did was they gave him botulism, which it helped a little bit, and they gave him the carbidopa levodopa. That's used for Parkinson's. What is Parkinson's? Little seizures, right? Little tremors. And it was working, and he was relaxing a lot more. So that trembling, the movements is called aphatosis. It's a word that you need to know, okay? One of the things also with seizures, cerebral palsy, many cerebral palsy have seizures. Remember, we have to take care a lot of times of their gums and their teeth. For instance, your Dilantin is one of those medications that can cause hyperplasia of the gums. And they can get all red and infected. And we don't want these children to lose their teeth because of these medications, okay? It's either Dilantin or Phenytoin, whichever name you want to use. These children, we need to keep them moving. We need them active. You know, that early intervention. These children need physical therapy, occupational therapy, speech therapy. And if they can't talk, like my little Jonathan was nonverbal, but he had a little pad he learned how to talk on, and he was being taught how to do colors and shapes. Yes, he's 7 years old, but at least he was doing that, right? They gave him a goal and he was doing it, and they were increasing that goal as he was continuing. Years and years ago, when I first became a nurse, we didn't do this for these children, and we didn't realize how smart they were because they couldn't talk, right? Well, today we've given that outlet. How can I communicate? They do have that ability today. So I think that's pretty neat what I've seen in my career and the advances.
I have a question.
Sure.
How long did it take little Jonathan to use did he have like a tablet or something? Because my niece has one and she's
He has a
trying to.
tablet. It takes time. It
It
takes
takes
time.
time.
And this boy went 5 days a week to this called a PPAC. It's a prescribed pediatric extend care. It's a doctor's order. So he was bussed in and brought home every day. And this place had in-house PT/OT speech therapy. So they worked with him constantly. It took a while.
Okay.
But once he started to communicate, then it became easy. It does take time and patience. Yes, it does.
Gotcha.
Don't worry, we'll get her there. It will happen.
Gotcha.
Good.
Thank you.
You're welcome. Braces are used again to try to keep those feet from foot dropping. We may not be able to walk today, but maybe we can get those muscles strong enough another day. So we want to keep everything open and active. And then any surgery for any contractures, if they happen to happen, of course, we'll do. Now, in CP, you need, again, established communication, right? They need to talk. They need to tell you what's going on. I mean, you can hear some things and know that they maybe have been incontinent, that their diaper needs changed, or little Jonathan, I used to hear him almost like squeal when he'd see me because they knew I was going to go up and hug him and kiss him all over because he was my little Jonathan. He was my kid. And this place knew that, oh, Jonathan is over there now when I'd walk back into where he should be. Nope, he's in speech. And I'd go see Jonathan. I mean, it was my little boyfriend. Establishing locomotion. How do they get around? They can just sit in one place all day? So yes, Jonathan had a wheelchair, but these kids, as they get older, they'll be taught how to use electric wheelchairs, getting around. Can you imagine? You can't get around, you can't talk. And now you have that ability. Oh my God, I'd feel great, right? Again, it helps and encourages them to be more. That socialization is so important. He was placed in a room with other children that had ADHD, ADD, some autistic children, and some kids with medical conditions that had to be there, which were cognitively aware and normal, right? This really made him socialize. He'd be sitting there clapping when we had videos up about everybody clap their hands, and then he would be doing these things because everybody else did it, and that was stimulating him intellectually, right? Again, that technology I talked about, and then multidisciplinary. This child needed every therapy he was getting, and the nurses that were loving him too. And kid was doing so much better in the 2 years that even I knew him. Remember, intellectually impaired children have the same psychosocial needs as all other children, but cannot express or respond as other children do. We sometimes don't give that child who can't express or nonverbal the ability to tell me or you what they want. But given that opportunity and that way to communicate, they will express themselves. And they actually are pretty neat kids. So the nurse has to assist the parents to understand what's going on. And the thing is, yes, these children can't do everything well, but there's going to be some things they do well. And we need to encourage, and yay, good job. That little yay, good job means a lot to these children. If you're always telling them, no, do it again, do it again, do it again, what's going to happen? I know what I would do. I'm like, yeah, I don't think so. And I wouldn't do it. Right? But we don't want that kid to be angry. We don't want them to be upset. So always look at the positives. So individual plans of care. Again, the family has to be involved because the family has to do this at home. I mean, most of these children are, and if they have that ability, go to these facilities. And many of them are awesome. That gives them everything they need. But they're there at the home overnight, 12 hours, and all the weekends and all the holidays, right? So family has to be involved. The family needs our emotional support too, to take care of them. We had a 20-year-old girl at the PPAC just about to age out, and she was CP, nonverbal again. And I called the mother up and I said, would you mind if I painted your daughter's nail when I come here? She's like, oh no, please do it. Now, I couldn't cut them, none of that, no scissors, but every week I would go in there and it would be like 6 weeks that I was doing clinicals, and I would go in there and I would paint the child's nails. And that little girl's big smile face was amazing. So emotional support, the mother got those nails done because I'm sure if she had a chance, she would have done it for her. And I gave that mother a break. So she appreciated it. And when that child did age out, she came over to find out who I was, to hug me, to tell me thank you. And all I did, I was the instructor, but I was painting her nails. And I was showing my students that that little extra means so much to her, the child, and to the mother. Um, if you have a child with these sort of, cognitive delays, the nurses need to know what they're able to do and not. These children will regress. And if you don't push them, it's easier for them. So we need to know what they can do. And home routines and schedules are very important. These children need to maintain routines. Again, you emphasize the strengths, good communication with families. If this child is in school or has that capability of going to school, we need to plan for that. Some of them have to go to school with, a person because of many medical conditions. So getting it planned, helping the parents do that is really important. And support. These children are not the only children like that. And there's a lot of barriers. And many parents have worked through those barriers before that parent. So these support groups can work really good for them. Some of these children, you don't know that they're somehow developmentally disabled. They look like normal kids. And then you have other kids who have unusual faces and they're not, developmentally disabled. So never label a kid until you know what's going on with them. If you have, suspicions, find out, ask, so that we can treat them in the proper manner. So concussions. I think the biggest thing I saw concussions with was playing sports, baseball and soccer. Those are the two big ones I always saw a lot of concussions with. Sliding into third base and the head hitting a knee and I hear a crack. And the child comes in and either they came in by ambulance, by trauma copter, or, the parents come in. So one of those ways they get to us. So if we find out they've been hit on their head, whichever way, we're gonna, number one, be aware of their level of consciousness. We wanna know where their baseline is at first, because when we see a continuing decrease in level of consciousness, problems are occurring and that must be reported to the physician. You would see decreasing level of consciousness. You would see vomiting in children. You don't see it in adults. You see it in children, head injuries, and headache that gets worse, that even if they're sleeping, it wakes them up. Those are big, big clues that probably increased intracranial pressure is going on. Now, sometimes you get the kids that are younger and they have some concussions because of a car accident. They are pushed forward, right? And maybe they have a bar there on their car seat and then their heads flip back a lot of times. So we've got to be really careful because it is a 2-point contact of injury there. So we got to make sure that do they remembering things? Do they know where they are? Head injuries, what do we see? Because of increasing intracranial pressure, the swelling causes areas of the brain not to get the oxygen they need, so hypoxemia, swelling, cerebral edema. And this, if we have all this blood and stuff going on in there, after a few days, this becomes an infection. And now you have more of a meningitis along with a head injury, which is a quite serious child. So hypoxia causes the brain to need increased energy. So what they do, the brain says, okay, I need more blood. So more blood goes up to the brain. Well, you're already having bleeding in the brain, right? And now you have this extra flow because the body says it's hypoxic. I need to get more there, puts more blood there. And what are we doing? Creating more swelling in the brain, right? Increasing that cerebral edema. And this is watching that intracranial pressure. If we have some sort of monitoring on it, remember it's pressure in the brain and it could lead to necrosis or death of areas of the brain. So, and it could lead to the death of a child. So concussion signs and symptoms, as I said, it's all about their their mentation? Are they awake or are they forgetful? Now, are they hard to wake up? Headaches, that dizziness, that vomiting, that diarrhea, all of these things we will see with a concussion, head injuries. Now, there's something called a shaken baby syndrome. These are children where, let's say they're crying, and then the parent picks it up and said, "Will you just be quiet? I need to sleep." It happens. It could be something that happened that, most parents will do that, but you don't know what goes on in a lot of parents' life. And this creates a lot of shaking in the head, and it creates a lot of blood being released in the capillaries, in the eyes, in the brain, and it can cause permanent brain injury or death. Now, what would you see? Well, you're getting increased blood's going in the head, right? And then it's lacking oxygen, so more blood's going in that head. So headache. A child with a headache, you're going to see them with their heads and the wincing, the grimacing of their face. Sometimes they even touch their heads. Then they're going to get drowsy. We don't know if they're blurred vision, or maybe you can see that they don't see, but vomiting is a big one. And dyspnea, we're going to see them. Sometimes if they waited too long, it could go to completely unconscious, and we can't get those children back. Now, there is posturing that goes on with brain injuries. We have decerebrate, we have decorticate. And it's decorticate is to the core, and decerebrate, the arms come down like an E. And this is just posturing that you will see, and there's some brain injury going on there. So, components, what do we look for in a neurocheck? Level of consciousness, pupils, vital signs, and their activity. Are they moving things at the way that they should? The one thing about infants, which is the best of all of them, if you had to figure out increased intracranial pressure, the young ones, that fontanelle, you start seeing that puffing up and they are quiet, sitting there, you know that there's something going on there. Sometimes it's the sutures. And the other thing is they get this cry that it's, once you work in the newborn intensive care area, you have a kid who's what we call a neuro kid, or a kid with that extra, maybe there's swelling going on in their brain for whatever reason. Their cry goes up about 3 octaves. And that that kid has some sort of neurological injury. It's not a normal kid's cry. You're going to look at the pain response, level of consciousness. If you can arouse them, you'll look at the cranial nerves. Can they stick their tongues out? I mean, all of these things we'll do as much as we can according to the age of their child. Are they sitting there normally, or are they posturing, right? Pupil response, huge. Are they equal? Are they reactive? Those scap veins in the newborn, the neonate, the infant, do we see them? Because we shouldn't. And then we're going to start to see different things like the spasticity of the lower extremities, which called ataxia. If they're walking, they're not going to walk well. This going to be very, stiff and spastic. And then we're going to see those morotonic-clonic from withdrawals. They're going to be pulling away, startles and pulling away on these things. Now, I live in South Florida, as I said. Near drowning is something that's on my mind. I've seen quite a bit of it. I even saw one of my physician's son at age 3 drowned and did a almost near drowning, which had lifelong repercussions. So it is the 4th leading cause of death in children under 19. And we look at near drowning, not that we got them out of the pool and they started running around right after all of a sudden they vomited water and then they were okay. It's 24 hours after. The signs of near drowning or acute respiratory distress do not show up till 72 hours. Because you've had an hypoxic episode. You swallowed water, right? No oxygen went in there. There was an area where your brain didn't get oxygen. And then what happens is after 72 hours, these kids are fine. Many of these kids, they're running around and like, why do I need to take him to the hospital? He's fine. It's not immediately. It's looking for them down the line. And all of a sudden they'll become tachypnic and tachycardic, and their O2 sats will start dropping. They go into what we call acute respiratory distress, and very dangerous, and survival rate is not great if they've gone to that point, okay? Priorities of treatment, always number one, oxygen, because we've aspirated it. And then, was the pool warm or was it cool? I mean, most pools are not 98 degrees, right? So most of them we do have to warm up. Submersion more than 10 minutes with a failure to gain consciousness at the scene. That is the one who's going to have severe neurological deficit, go into that acute respiratory distress, and these kids usually will not make it. All right, musculoskeletal. You know, kids are born with all sorts of musculoskeletal problems, and then of course they get their own as we go on. So let's look at it. We have muscles and we have bones, and they work together. And we know it provides support for the body, and your child is able to move where it needs to move, right? Hyperemia is the
Excuse me, Dr.
Yes.
Excuse me, Dr. Bogart.
Yes.
I have a question. Are these slides accessible for the students?
I will make sure it's posted to you on the announcements when I put your recording so that you will have them.
Okay, thank you.
And then if you haven't gotten other ones, you let me know and I can post them.
Yes, ma'am. I got through the first exam, but barely by the skin of my teeth, just by reading the book and the reviews, but
Okay.
I never find the slides.
Okay. All right. I will make sure you get your slides.
Thank you.
No, and any of you also, if you ever see anything you're not getting, just let me know. I will ensure that I give it to you, or I'll have your professor give it to you.
Sometimes the slides are not on the phone and Canvas, but if you log in on your laptop, just go all the way down, scroll all the way down to the end of the screen and you'll see, because I wasn't seeing it on my phone.
Is it in modules or announcements?
The announcement, but
I've seen her in the announcements posted.
but it shows on the laptop sometimes and not on the phone.
Okay.
All right. So if you see it today and it's not there, send me a message.
Yes, ma'am.
Okay. All right. Musculoskeletal system. How do we assess it? Well, just look at the way the child's walking or limping, right? Or unable to walk. That's going to tell you. It's going to see. Then you look at their muscles. Are they smaller, bigger? Are they the same? Is it equal sides, right? We're going to touch them, feel them, range of motion, seeing are they moving the way that they should. Neurovascular checks in any musculoskeletal condition is very important. Checking, do we have capillary refill? Do we have pulses? Are they got good movement? Can they feel those things? All the 5 Ps, right? Important that we know that these things are working well so that we can intervene quickly. If we have a child that's not walking independently by 18 months, something's going on. There's a delay. This is a case of intervention where they're going to need to have physical therapy or occupational therapy, and it needs to be worked up. Why? Why aren't they there? And the great thing about kids, they catch up so quick. Once we introduce these things, these kids are great. So we just know that the musculoskeletal system is growing incredibly. I mean, just think about the first 6 months of life. This infant's gaining 1 inch of length per month for the first 6 months. I mean, 6 inches of tissue, which is muscles and your bones and etc. So that's a big thing. Now, toddlers start to walk, right? Usually they say at 1 year, they should be able to take a couple steps. I mean, if they're right after that, you know, it's fine. I mean, my kids never walked till 15 months and then they ran. They never did walk. But the thing is how they're walking. Toddlers still waddle, right? They're still trying, they're uncoordinated. They're still trying to move and their arms are not swinging as they walk. If you ever notice when you walk, your arms are swinging, right? So by 4 years old, children now can hop on a foot. And again, those arms are swinging. It sort of gives them their balance. And by 6 years old, everything should look like an adult. Their bodies, their muscles, it's all mature now. So again, looking at the symmetry of movement and making sure that they're same on both sides. One of the things doing a neurological test is looking at those reflexes, looking at, the senses. Like, for instance, we know that children at birth are going to have the Moro or startle reflex. That Palmer is reflex, or it's voluntary. And then it's going to start with the walking and all of these reflexes. These are things, when we're concerned about neurological conditions, we are going to look at these reflexes to make sure that they're able to do them. And then we'll look for other things. Why are they behind, or why aren't they? Of course, we'll look at bones. I mean, maybe it's malformation of bones. We don't know. I mean, children should have the bones all there, but it doesn't mean they always do. Do bone scans, CAT scans, MRIs, ultrasounds. And one of the things we do, especially with children who come in limping or complaining of pain in the hip, the knee, we do a CBC and we look for a white count. Is there an infection somewhere? And then we do ESR, which is a sedimentation rate. Sedimentation rate is an inflammatory factor, which means if there's inflammation anywhere, we can say, oh, the sed rate's elevated. This child might have like rheumatoid arthritis. Or it might be osteomyelitis that's going on. Looking further, do I see redness, swelling in any area? And then there's another HLA, B27. Listen, rheumatoid factors are hard. They're still working on them. There's nothing, set in stone. Some of you in my class know that I have rheumatoid arthritis. It took them 8 years to diagnose me. I mean, with all of the symptoms. Oh, you're fibromyalgia. I'm like, yeah, no. Finally, they found one test that, oh yeah, okay, I guess you are. But still, it's really difficult to diagnose these children. So let's look at some different treatments. Arthroscopy. This is when we look inside a joint. We use this a lot in knees. When they have meniscus tear, you hear the sports people, they have a meniscus in their knee, it's the tendons tear. They do arthroscopy. It's just a scope, look in there, see what's going on. Sometimes we do a bone biopsy, and that bone biopsy may be looking for osteomyelitis, or it might be looking for cancer. Osteosarcoma is a cancer of the long bone, usually the femur. Where I'm seeing, is it cancer? Okay. Traction. Traction is something we use that straightens the bones, and it really decreases the pain on these children. We're going to go into it some more with some Buck's traction and Bryant traction just in a second. And then, of course, children who break their arms, their legs, whatever, or sprain it, we're going to put them either in casts or we're going to splint them, because it immobilizes their injuries and allows them to heal. So you have a kid who was running, kicked the ball, and fell, twisted the ankle, and broke whatever. What do we do? What is the immediate treatment of it? And we can do it without a doctor's order. We're number one, put them down, stop. Okay, you don't play anymore, whether they want to or not. Ice it, elevate it, and an ACE bandage, compression. And that will decrease the swelling there. Now, one of the things that we think that contusions, sprains, strains, they're really not that much. Well, contusions, sprains, and strains do cause some swelling, right? What's inside those legs? Also blood vessels, right? So what if that swelling got really big? Would it occlude the blood from going to the feet? Oh, yes, it would. So what else do you think we're doing when we're doing checks on these broken or sprained areas? Neurovascular checks. Is there a pulse? Is there capillary refill? Is there movement? Is there numbness in those extremities? Really important thing that we do. You know, that getting them up contained in ice immediately, as I said, will decrease the amount of swelling. You know, I was a sports kid through my whole high school, college career, and I've sprained my ankles. I can't even tell you. I could feel it swell. So I'd be like, get the ace bandage and wrap me up quick. And I'd have my foot over my head because I know the least amount of swelling would decrease the amount of recovery time. Car seats, we know, is part of our safety. We know bicycle helmets should be used if they're riding a bicycle. There should be pool fences. There should be window locks of some sort, not necessarily bars, but something. There should be deadbolt locks. My kids, before I put the deadbolts up higher, would put a chair up and open it at 2 years old and try to walk out the front door. So I really understand deadbolt locks. Oh, but then they would take the screens off the window, open the windows, and go out their bedroom windows. So I had to lock them into their bedrooms and lock their windows. So locks everywhere to prevent them from harming themselves, you know, whether they're getting into materials or chemicals, whatever. Now, there's all sorts of fractures. These are the pictures of them, but these are the names of them. So if you're reading the name, you don't understand, go back to the picture here, okay? Let me hit on a couple of them that you really need to know. Green stick fracture. It's an incomplete. So the bone, one side is broken and the other one is just bent. It didn't crack yet. So that's like a partial fracture or incomplete. Compound fracture, the bone comes out of the skin. Our biggest concern, that bone is sticking out and in the environment, infection. That's where osteomyelitis can occur. Simple fracture is what most kids get. Fall off the gym, you know, fall down off of the monkey bars. They put their hands out, they break a bone, and we just put a cast on it and it's fine. Nothing's sticking out. And then the one I think is the worst that I really don't like to see is the spiral fracture. Is when the kids, they sort of forcefully swing that kid around by their leg or their arm and it's twisted. That is indication of child abuse. Now, what do we do for child abuse? I've seen a few cases in my life, some that I don't like to even remember. Remember, it's not for us to yell at the person who brought the child in. It's to keep the child safe when they're there under your care, to make sure that they're not going home to a bad environment again. And remember, just because they come in with something suspicious doesn't mean that there's abuse going on. There's other things that could be happening that can explain it. So, but again, just keep your child safe. Again, the sprains, the strain, contusions, be careful of the swelling and the blood flow. So a fracture is, you know, they fall down. It's an accident. What do you see? Well, it's going to hurt. It's going to swell. And it's going to be, you can't move. Let's say it's in the wrist, the radius or the ulnus. Let's say one of those. And it's hard to move their hands. And you might see some bruising there. Children, you know, 4 weeks, the cast is on and off. Adults, it could be 3 months, 4 months. They just heal a lot quicker because their periosteum is stronger and thicker and less stiff on mobilization. One of the things we need to worry about is what we call the epiphyseal plate, and that's at the end of the bones. If it fractures the end of the bone, that's where the bones grow. So we have to make sure that that's in really good position so that it continues to grow the way it should, and you don't have a crooked arm or a leg. So now we're going to go into some sort of traction. Now, in adults, you've heard of Buck's traction for a fractured hip, right? Have you heard of that in adults? All right. Well, children don't get fractured hips. They're going to get fractured femurs. That is the one that we're going to be using it for. So Buck's traction, Bryant's traction are used for those fractured hips. Okay. Now, another thing, Bryant's, this one here, is pulling them up in the air. This child can't weigh more than 30 pounds. If they're more than that, this doesn't work, okay? So These children, they put them like this and it pulls the bones so that they're straight. The ends of those bones, if we let the muscles pull them, they're going to go crooked. And they're both sharp on each edge. And it's painful. And it, hits all the nerves and the muscles. And it really is miserable. So pulling it there helps them. They should keep the traction on 24 hours a day. Okay? And what are we going to be doing? Checking neurovascular signs, keeping the weight off the floor. And if it was bucks traction, we're not going to allow that foot to be on the end of the bed. It has to be off the end of the bed because then there's no pull going on, okay? This one is similar to bucks, but it's a double traction that we do. One set pulls in two directions. And then we have what we're doing these tractions for. Body alignment, the head of the bed should not be elevated too high because then the pull doesn't occur the way it should. Again, the heels should be up off the bed and not on the end of the bed. They should have on something to prevent blood clots, and anti-embolism stockings, or those little pump things we have. They got them for kids too. Again, neurovascular signs, and please document them. And always you measure how much weight was on that bed. I mean, there's people who come in who visit, or people just pull off the weights because let me just pull it off. And it happens. So make sure you check the weights there. Make sure they get medicine if they're hurting and they are immobile. So now you've got to worry about constipation. These children can't get out of bed. That traction cannot be removed. So you're given pain medicines, they're going to be constipated. So making sure they're getting medicine and whatnot to help them, increase fiber to help them stool the way they could. And then older kids, that trapeze, so they could pull themselves up and down. So this is all of the things I was saying. No knots, no bed linens. And again, you should not having them touch the end of the bed. We need it to pull out because it pulls it straight and it decreases pain and muscle spasms. These are the 5 Ps, which I've been talking about. Neurovascular check. So it's pain, pulses, pallor, paresthesia, and paralysis. Does it hurt? Do I feel pulses? What's the color? Is it pale or pink? Is it numb? Is it not? And can I move it? And here is another depiction of, again, the tractions. So we are going to be doing those neurovascular checks, very important thing. Again, it's a safety, making sure is blood going where it should go. We think that since it's pulled straight, everything's fine. Never assume. Always check it and always document it, like I've said. Remember when you have a device which is called an external device. These things are used sometimes. We use them to, sometimes you have one leg bigger than the other. This is the way a lot of times they'll use it. And they'll break the bones and open them up and put this external fixation device there. And the bone by itself will make some more bone in between the two open ends so that the child's not going to have one leg 2 inches shorter than the other. Another time it's used is for really massive fractures, that there's so many bones everywhere, they have to do something to put it into place and it doesn't move and they have to have easy access to it. So the big thing with this is pin care, because remember, it's going right into the bones. There's pins directly through those legs. So meticulous pin care is important. And then, of course, watching for the osteo, which is fever, redness, swelling, and pain. Usually skin contaminants is staph. Staph is what you see, and it's the common cause of osteomyelitis in children. So open bone fracture, you worry about staph infections. What do you see with an infection? Any infection? Well, an elevated white count, right? Infection, if it's a virus infection, white count's normal. Bacterial, elevated white count. Again, that SED rate, which is the inflammatory factor, there's a lot of inflammation going on with osteo, that will be elevated. We can see some fuzzy stuff on x-rays, but a bone scan is a little bit better. So how do we treat osteomyelitis? Well, we are going to put them on a long-term, usually up to like a month or more, of IV antibiotics. Sometimes they have to go in and drain it because it's full of pus and contaminants, right? And they need to get it out of there. And remember, they need this leg is going to be immobile. They shouldn't move it. That they're going to need physical therapy when they're done, because you do get atrophy of muscles. Even children get atrophy of muscles. And again, give them something for pain. And in children with anything that holds them in bed and they can't move, something for diversion, whether it's coloring, whether it's an iPad, whether it's a game, TV, whatever that child likes, keep their brains active. And of course, they're going to keep all the other body parts good with physical therapy. Casts and splints can be made of anything. You know, I worked at a pediatric hospital and I was lucky because they had colors. They had pinks, 2 types of pinks, 2 types of blues. They had green, yellow, orange, army, rainbow. I could go black, I mean, red. There's so many. And it actually took the child away from thinking about they're getting a cast because they were getting a cool color on their leg or arm. So remember, when you get a cast on, you are now covering an area and there's swelling underneath from a break, right? Be careful of the skin integrity, nothing going down into those casts, right? If it's getting swollen and now they can't move and they're getting the colors, it's becoming white and not so good capillary refill, could be compartmental syndrome. So again, watching those 5 Ps, the pain, the paralysis, the pressure, etc. Always look at those things. When we have a child, depending on what sort of we used on them to fix a fracture, depends on how long they have to maintain like more of a bed rest or minimal activity. Usually casts 24 hours, they're pretty well set, but they're not going to tell you to go running around and go out to the park on your crutches or with the arm. They're not going to do that. Try to protect it. Keep it elevated because it decreases the swelling. And again, can I say it again? Frequent neurovascular checks, right? And we need to teach these families and the child how to take care of their cast. I've had children go home, put their bathing suit on, and jump right in the pool after they had a cast put on their arm. And not did it once, but he did it twice and came back in 2 days in a row. And the mother was at wit's end because you have to come back to the ER, you have to check back in, you have to have the old one off, put a new one on because it can grow fungus and who knows what else underneath there. So they do really teach all about keeping those casts nice and dry. Also, too tight, too loose, both of them are important. Again, go back to the physician. Now, let's go into some muscular degenerations or muscular dystrophies. They love to pick on Duchenne muscular dystrophy. And most Duchenne muscular dystrophy, it is usually boys. I mean, this happens to be a girl here in this picture. I don't know if she's Duchenne because I didn't get that picture, but it's boys ages 2 to 6. And you're going to see that they have had a delay since birth. And as they get older, you're going to see their calf muscles become big, thickened, and hypertrophied. Okay. But they're going to be like waddling, falling. They're going to look clumsy. And the other thing they do is, have you ever gotten off the floor and then took your hands and walked up your legs to get yourself up? I mean, I know I do because the aches and pains in my body, but these are 3-year-old kids. They shouldn't have to do that. And that's called Gower sign. And you'll see that. These children are usually have cognitive delays. And because they can't move as well as they should, many of them are overweight. So one of the things with muscular dystrophy, Duchenne's, it is a progression. Duchenne usually dies from cardiac failure, respiratory failure, usually in your adolescence, okay? Becker's is another one, but it's a little slower, so it lasts longer before the end, but same things happen. And remember, these kids are usually have inability to get around or express themselves. A lot of these kids will get those wheelchairs that they can motorize and get around. We try to do physical therapy to keep them moving as much as we possibly can. Coxavera is when the hip is displaced. And it's usually at that pre-adolescent where they're growing so quick. And it is painful and it hurts. So what they can do is put these children on the Bucks traction, which will pull it. And then many times they'll do just the traction and some NSAIDs, but many of the times they have to go in and surgically replace it and put it back where it should be. One of the things that this slides don't mention is something that was on your HESI last semester, and it's all about the hip dysplasia in the newborn infant, where the hip socket is not born in. And what they do is they put these children on a Pavlik splint, and it causes the legs to be abducted. And it's just putting them in that 23 hours a day. And we put this over a t-shirt so you don't have the rubbing of this Pavlik harness creating, rubbing issues and breakdowns. And these kids do really well, really quick. So Pavlik harness on a hip dysplasia on an infant. So lave calf perf is a aseptic, which means it's not an infection. It just all of a sudden blood flow stops going to the head of the femur. Leg calf perf disease, coxaplanets, the other type of it. So how do we treat this thing? Well, again, bed rest, put them on some Bucks traction to relieve that pressure there. And these children usually will heal from there and do okay. But it does take some time at home again. You usually see these kids, all of a sudden they'll start to hurt and they'll limp. And kids, when they hurt, you'll see them limping and you'll say, oh, this is real. Look at this. You'll see it usually with the cast, the braces, with the splints going on, the Bucks traction. You will see them that heals just, by itself. We have no time frame. It just happens. But many of them, not many, but some, might need a hip joint replacement, but later on down in their life. I've mentioned the osteosarcoma, talking about that cancer in the long bone. These are usually your adolescents. This is a bone, as usually the femur. They say long bones, but I see a lot in just the femur. And you have to take the whole bone out. So what happens when you take the whole femur out? There's no bone left, and all there is a hip, right? So how do we let these children become mobile? Well, what they're doing now is what we call a salvage. We salvage the limb. We salvage the lower limb and hook it up to where that hip was. And it's a long surgery, but once it's done and healed, they can put a prosthesis on it. And now these children can get around. So salvaging the limb, but usually it could be an amputation or salvaging it. And, the outcome always depends on if it's metastasized already. And then you will see children with retinoblastoma have a higher incidence of it. So I gave you a picture of that limb to show you what a salvage limb would look like. They put it backwards, but it goes into that prosthesis so people don't see it. And they could get around really easily. There's something to put there for them, right? And again, you're going to treat these children like they've had an amputation, that phantom pain. So we'll treat them with, when we have a child with Ewing's sarcoma, again, it's another cancer. It's another one about the marrow of the long bones that has it. And again, we do radiation therapy and chemo. Many times it's already metastasized when we figure it out. And then of course, then your prognosis is not going to be good. And Ewing's again is in your older children and early adolescents. Now I've mentioned a little bit about rheumatoid arthritis or juvenile idiopathic arthritis, JIA it's called now. And we see it in little kids. And this is one of the kids who come in who can't walk or limping. And that usually brings them in. And especially when you see them stiffer in the morning. And as they move around during the day, it gets better. That is just like the adults. Wake up in the morning, you're stiff, it's hard to walk. Once you get stretched, get moving, and then you're okay. There is no cure. As I said, there's really no test. It is an autoimmune disease where the body attacks the joints and connective tissues and could attack some of the viscera. So this is something that's lifelong and they need to have treatment of it. And some of the things we'll see, as I said, the morning stiffness, you'll see them hard to walk, the limp, and there's different types of juvenile idiopathic arthritis, even the adult brand, there are different types of it. Is it one joint? Is it multiple joints? One side, both sides? So sometimes the systemic one is the one that I believe is the most severe that you do see. You're going to see them, they spike these big fevers. They have this rash that goes all over, their tummy hurts. And again, this is all inflammation that's going on. So they're going to measure that SED rate, that ESR. The other test that we use is called a C-reactive protein. And again, another test for the inflammatory factors. We use that a lot in your newborns. That the C-reactive protein can tell us even before sometimes weight counts go up, something's happen. The polyarticular is 5 or more joints. Again, they're red, they're swollen, they're painful. And this is girls. The pork-articular is 4 or fewer joints. That's usually kids, again, younger than 3, again, mostly girls, and it's the big joints, hip, knees, ankles, and elbows. Something that can also happen, and why these children should be checked by the eye doctor, is iridociclitis, and it's redness of the iris, and it could cause decreased vision, so it really needs to be followed closely with ophthalmology. What is your goal with arthritis? Well, you want to reduce that pain. You want them to be able to mobile and to move around and they can grow up and be normal, right? We want them to be independent. And these children need to know what they have to do to move around. And usually it's get up, move, and then a lot of them are put into exercise classes. Things like taekwondo and karate, swimming. These are great things that gets that kids moving every day, and it gives them something to achieve, and it helps them to keep limber and keeps those bones from getting all deformed like they can be. We know there's great times and there's times that they hurt. It's just part of it. Just know that talking with a child, the family, that there are normal, that this is what goes on and what to expect. Because, this kid, they might be planning on a trip and all of a sudden the kid goes into a flare and he's hurting, and that could delay it. So letting the family know that these things are going to happen. Another thing that goes on is torticollis. Their neck is to the side. It could be what they were intra utero, or it might be that's the way you feed the kid, right? And all of a sudden they get a stick neck. And what it is the shortening of the sternocleidomastoid muscle, which is the one right up the neck to the shoulder, and it shortens. So then your neck is going to be that way, okay? And a lot of times we clear that up through exercise, and we're going to clear it up with a little bit of heat, which can help there. And physical therapy can also be done with that also. Scoliosis, S-shaped curvature of the spine. So it goes S-wide. So what happens is these children in that pre-adolescent growth spurt, they're growing that 25% of their body weight between like 12 and 14, and it gets crooked. So sometimes it's due to poor posture, but sometimes it's just the way that the spine is gone. You will see one shoulder higher than the other, and it looks like one arm is longer than the other. And we see this a lot in girls. Remember, these are adolescents, that their spine is curved. Remember what they are fearful of, body image. They don't want to look like that, right? They say if you have a curve greater than 40 degrees, which means it's really S-shaped, that one will need surgery. And they do this spinal fusion called Harrington rods, and they try to make it straight as possible. Any other kid less than 40 degrees, what they'll do is they'll put them in these braces. Here's a pretty black and purple one, or just a white one, and we put a t-shirt underneath it, and it will hold the child straight, and we have them in therapy, physical therapy, to strengthen their muscles. They can only take that off 1 hour a day to bathe and then put it on again, and it does straighten it up. Sports injuries, of course, kids are out running around, they're always getting hurt. Could be due to not, warming up properly, or just really wanting to play the game so well that they hurt themselves. We can have those concussions. We can have those stingers or burners. You slide and you get these big abrasions. The knees, ankles is what I used to always do. Muscle cramps, and of course, shin splints, running too much, too hard, too much. It can happen in any sport. Any sport can also cause it. Gymnastics, these children are doing repeated the same thing over and over again, stretching beyond what most people do. So that's why gymnastics is at the top of the line there. And then, of course, it's all the other sports. And let's talk a little bit about family violence. Something we don't like talking about. We don't want it to be real, but it does happen. It could be the spouse, could be the child, and it could be neglect, or it could be maltreatment. So what are the triggers? What causes all of a sudden a family to take out all of their anxiety on the child? Well, it could be that the child is disabled or hyperactive, or you're a foster parent. Sometimes it has to do with all of a sudden, your husband lost a job, so now it's financial, right? Or maybe that parent was abused as a child themselves, so they don't know how to act. Or it could be something to do with, substance abuse, drug or alcohol. So these things are the triggers that we see it. So what are the differences? Well, emotional is a lot of verbal, which makes them destroy their self-esteem. Remember, when you get to be that pre-adolescent, adolescent, your whole thing is about your identity, like what Erickson says, right? All about body image. So it destroys that, and these children are going to be depressed, and then it's showing signs for depression and suicide. Got to be careful with it. Emotional neglect means they're not telling you they love you, don't want to hug you. You're just there, and you just feel alone. Sexual abuse could be anything, that they touching you in ways that you shouldn't be touched. Physical neglect, you're not having food, you don't have electricity, you don't have a bed, all those things. And then, of course, physical abuse is, they're hitting you of some way, some infliction of injury. So what is your job as a nurse? So as I said before, anytime that you suspect abuse, you are there for the child. You are not there to make determination who did this, okay? I have 2 different cases of child abuse that I'll never forget. One, the child was 7 years old, was tied up in a room, and he was withheld any food or nutrition. When he came into the ER, he took his last couple of breaths, and we brought him into the trauma room, and we had to resuscitate him, and we had to even do intraosseous IVs, because He had no fatty tissue. I mean, he had just bones with skin hanging over it. He was extremely malnourished. So that case, you know, we knew that's child abuse, very obvious. Then we've had the child abuse where infants have come in, where they've got fractured skulls, and then we take x-rays of their body, we find fractured ribs, fractured femur, fractured humerus. I mean, but then who did it? It's at that time, let the authorities do what they need to do. So what did I do when I saw these things in the triage area? I told my charge nurse and I told the charge doctor what my suspicions were. And then they took care of it. So just to let you know, both these children are safe today because I happen to know the lieutenant of child abuse in this county. So I was able to follow it up and he did give me that information. So you call Child Protective Services that, you know, if you see something going on in your neighborhood and you think, you can call it anonymously. We know that they have to go to that house within 48 hours and it has to be reported. How do you assess it? Well, you can take and do an assessment of the child. They come in, let's say, with a fractured arm. And then when you're putting on, let's say, a gown to put them into the x-ray, you see all of these other marks. These will be those things that will alert you something's happening. The color of the bruise tells you when it happened. From 1 to 2 days, it's just swollen and tender. 0 to 5, it's red or purple. From 5 to 7, it's green colored. And 7 to 10, it's yellow, and then it gets to brown. And they do follow those colors. The kid with the fractured skull was yellow and green by the time I had seen him. So that poor kid had had a fractured skull a long time. So it's hard to take a history of it. And it's hard to some cultures to talk about it. So the one thing that I do is I just take an assessment, ask those questions. I let the authorities come in, the social worker come in, you know, and ask all the deep down questions for it, okay? All I get is, well, how did it happen? Whatever they said, okay? And then I give it off to the professionals that they can do about it because the Child Protective Services are gonna oversee anything that goes on. Any questions? A lot of information today. Yes? No? We do have a quick cahoots. I'll run it quick as I can. We should run to right to 5:30, okay? So go to kahoot.it, PIN number 2230819.
Will you be posting this Kahoot?
Absolutely.
Thank you.
Get all of it. I'll go back for the last couple of weeks since week 4 and 5. I'll post everything for y'all. Is anybody else gonna play? All right, let's get her going so we can get you out at a decent time. I'm usually on time. Week 5, chapters 23 and 24. The nurse explains that Brian's traction is reserved for children who weigh less than how many pounds? It is 30 pounds, okay? If they're over 30 pounds, it doesn't pull properly and it's not gonna work, okay? So up to 30 pounds, which means you're toddlers and lower.
Can you
What
put the pin in the
intervention-
chat?
What intervention will the nurse caring for the child in buckskin traction implement? Your PIN number 223-0819. So you're in Bucks traction. What do we have to do? Well, we don't have to get that kid and help him being pulled up. We want the heel off of the bed surface, and we don't want it on the foot of the bed. These kids have to be in a low Fowler's, not a high Fowler. It takes the traction off and it won't work. What will the nurse include when caring for a child in Bucks extension? Well, number one, I could tell you is you're always going to be doing neurovascular signs, right? That's for sure. We're never releasing a weight. We are not going to have those hips up in high Fowlers, and we want the weights off and dangling. We're just worried about any irritation from the traction itself. Yes. What statement by the mother indicates understanding how to administer oral antibiotics for otitis media? So remember, otitis media is when it goes through the tympanic membrane and into the ear, and it swells and it hurts. You're going to make sure you medicate for pain for those children, and ibuprofen works well, but also make sure they take all the doses that they're supposed to do. You're not going to share it, not till it stops. If you don't complete it, it's going to come back. And remember, this affects hearing on that child. Another multi. What is the best way for the nurse to communicate with a 10-year-old who has hearing impairment? So all of the above. I mean, and this is like, they don't hear well. You've got to make sure, get on their level, face to face, look at them, and then short, clear sentences. Don't be yelling at them, over pronunciating. They'll be, feeling not great you doing those things. Like, what are they doing? What is the best way for the nurse to communicate? Oh, with another one, same thing, sorry. The best way to communicate with a child who has a hearing impairment. I don't know how I got that twice. Just in a different way. Again, face them, and then those short sentences. Very good. The nurse is reviewing the characteristics of Ewing sarcoma. Which statement indicates understanding of this disease? Remember, Ewing sarcoma, again, is a cancer of the long bones. It is similar to osteosarcoma, but it travels differently, and it's actually more susceptible to metastasis. It's what we do to help this shrink it, get rid of it, is radiation and chemo. Amputation, usually not in Ewing's. That's osteosarcoma. What characteristic manifestation does the nurse caring for a child with Duchenne muscular dystrophy document? Duchenne muscular dystrophy, progressive muscle wasting, usually boys, ages 2 to 6, around that area. And they exhibit certain things. They're cognitively delayed. They're very clumsy. They have hypertrophy of their cast muscles, not atrophy. Hypertrophy means they're big and thickened. They're not atrophy or thin. The nurse is providing instructions on how to treat a sprained ankle, a statement that needs additional teaching. It means which one of these isn't right? So you're not going to put anything warm on there because that warm's going to increase circulation and create more swelling. You do not want that. How does Russell traction provide adequate skin traction? That's that double traction, the bucks with an extra piece there. So this is the one that has pulling in two ways. It's up and out, and it's more of a correcting thing. Sometimes Russell's works better than just plain old bucks. What finding with the nurse assessing the neurovascular signs of a child in Russell traction report immediately? What neurovascular status? You're going to report ASAP. Like what's not good? Remember the 5 Ps. And it's the color. The color's not good. Everything else is good, but bluish color, there's no perfusion. What intervention is appropriate for a nurse assessing a pre-adolescent child for scoliosis? Assessing the child, as in what are you going to see? There's nothing to do with the knees and the legs. It's all about the upper area. So you'll see them go forward and you're going to see their back is going to be crooked and bent to the side. And if they're standing up, a shoulder's lower and an arm looks longer. Very good. What nursing action will significantly decrease the risk of serious complications for a child in Bryant's traction? Bryant's traction, they're sitting straight up in the air, right? The legs are up, child less than 30 pounds. And we're going to do neurovascular checks frequently. That serious complication comes from lack of blood flow, and having them sticking up in the air could decrease blood flow. So that's what we do. Neurovascular signs, number 1. Which intervention would be helpful in relieving morning discomfort associated with juvenile rheumatoid arthritis, or JIA? A lot of things to do with JIA, JRA has to do with keeping it moving. Many patients like heat, many patients don't. I don't like heat, I like cold, but whatever works for that discomfort. But in children, usually warmness on, let's say their knee is what bothers them. Getting it nice and warm will help it move. You don't want to splint these children because then what happens? They're not moving it all night. And non-movement causes pain, okay? What instruction would the nurse provide to an adolescent who has been fitted with a Milwaukee brace? That's used for scoliosis, Milwaukee brace. Remember, these are usually girls, those pre-adolescent, early adolescents, that crooked spine, S-shaped, and they got to wear a brace. What is the big thing about brace? You must wear it 23 hours a day, and you put the brace over a t-shirt so you're not sweating with this plastic against your skin or that rubbing, so you're preventing skin irritation. 23 hours a day. Which observation makes nurse consider the possibility of child abuse when a mother says her young child fell? When you're seeing all of those different color bruises, aren't they telling you different days or time when they were bruised? Absolutely, that one is what the ones you will see. And it's like, and you also see like broken bones, like an x-ray, different levels of healing. That's another sign that will tell you some child abuse is going on. On entering the room of a child in Buck's traction, what observation requires a nurse intervention? And we don't want those heels and feet against the end of the bed because nothing's pulling. We want that pulley to pull so that we take those broken bones and pull them apart to decrease the pain. Very good. What type of fracture would be the most likely to alert the nurse of the possibility of physical abuse? And that's your spiral fracture. That's one that you need to remember. You hear that there is a spiral type fracture, always think child abuse. And again, protect that child. A multi. What factors may trigger abuse in a parent? A parent's abusing their child. What are those things that might trigger them? Substance abuse, not necessarily overwhelming responsibility, but it could be. So I put it there. Being abused as a child, absolutely. Financial problems, yes. That knowledge deficit, even children raised by parents never had another child. It's not the reason for the child abuse. It's all of the other things. So very good, guys. What assessment made by the school nurse would lead to the suspicion of strabismus? Means that binocularity, they're just not getting together. They don't work together, the eyes. They can't put a finger, they're both not going there. They both go there separately. And that kid's going to sit there and cover an eye. And they do that because they only see one. They're not going to see double. What might the nurse explain as a common treatment for amblyopia? Amblyopia is also called a lazy eye. So lazy eye, you want that eye to work. You're lazy, I'm going to make you work. Cover the good eye and let that bad eye work for itself. And that's usually the treatment right there. Make it work, the muscles. What assessment does a school nurse recognize as a cardinal sign of hypema? And that's that dark red spot in the front of the iris, and you're going to see it on the eye. See with the naked eye, you don't need any equipment. What does a nurse explain to the parents of a child with febrile seizures? It happens when the temperature goes up quickly. It's not from a big temperature. No, actually, that's when they're really safe. It's when they go from 98 to 102 in 20 minutes. That's when they have seizures. Child experiences episodes where he appears to be staring into space. What is that called? Staring into space. What type of seizure is that? It's called an absent seizure. They just you're talking to them and they're not responding. Or it could be like a little slight twitch of the bottom of an eye, something very, very minor, and that could be an absent seizure. What is an appropriate nursing action when a child has experienced a generalized tonic-clonic seizure, a grand mal? What do you do for them? So the biggest thing is to protect them. So anything in the bed that's sharp that could hurt them, get rid of it. Head of the bed down, turn them to the side. Get the side rails up, pad them if you can. But you're going to do nothing like putting a tongue blade, you're going to break their teeth. And you don't want to restrain them because they just need to move. Your job, protect them from safety, and monitor. When did it start? When did it end? And what did you see moving? And then document it. The legs of a child with CP cross involuntarily and exhibits jerky movements with his arms. What type of cerebral palsy is this? And it's called spastic. Spastic cerebral palsy is that, they're jerky. They can't control their movements. That is spastic. That atherosclerosis is where their hands, it's what it's generally called, the positioning. Spastic is the type of cerebral palsy. What assessment findings in a child with meningitis should be reported immediately? It's that drop in blood pressure. Blood pressure goes down, perfusion stops going from the brain. The brain says, oh, I need oxygen, and creates more blood going there. They have meningitis. They already have swelling. Now they're having more swelling. So the drop in blood pressure is the most important thing that you need to notify the physician for. Which nursing assessment suggests the child has a concussion after a child fell and hit his head on the ground? What is the big thing you see with concussions? With, kids hit their heads. I mean, sports is a lot of the times that I've seen. And the biggest concern you're worried about is the level of consciousness. So can't remember what happened to him, or can't remember he asked 3 times, did we win the game? Did we win the game? Was I safe? Did I make it to third? I mean, those are questions you'll hear repeatedly. So it's their memory. And last question. A 6-month-old child gets inoculated with Haemophilus influenza type B. What does this immunization protect against? And it's influenza, very simply. Very good. Well, that is ours for today. Number 3 is Jeep Girl. Okay. Number 2, Kiki. Number 1, E for heart and key. All right. Anybody have any questions at all? Appreciate your patience.
The only question I have is these slides going to be posted, right?
I'm going to post you everything. Don't worry. You get the slides, you get the Kahoots, and you get the recording. And I'm going to send you last week's too. So you're going to get everything.
Thank you so much. Wait, you know,
My
I'm not
pleasure.
in your class. I'm in Miss Rebecca's, so.
That's not a problem. It's not a problem.
Thank you so much.
I'm taking care
I
of Dr.
appreciate it.
Yamraj stuff, so don't worry about it. I'll get it there. It's been a pleasure meeting everybody. I love the questions. So thank you all for a good class.
I'll be able to see it as well. I'm in the Tuesday class.
I will get it for you.
I'll see y'all later.
Absolutely. I will put it there. Not a problem.